annual, hopefully annual, 2015 MedWest Speaker Series featuring therapeutic modalities. We have 3 guest speakers that have flown in to speak to us today. Before we get to that though, I'd like to welcome you all for attending live in person. For some of you that may not know this, we are broadcasting this live to people across the country, some folks in the States, and I'm not sure there's a couple people in Europe, but if there are, hi Europe. Anyhow, this is the first time we're doing it, so we hope it runs smoothly. If you have any questions, again, just let us know. Again, thanks for attending. Everybody out there in the virtual world, thank you for attending as well. I'd really like to thank MedWest for being one of the sponsors. I'd really like to thank Mount Royal University for hosting, the Alumni Association for their donations as well, and all the volunteers that have made this possible. So I'd like to give them a round of applause. Just some logistical things. First of all, we have 3 speakers and we'll have a break in between each of the speakers. So you'll have an opportunity to grab some refreshments, go to the bathroom, and get your texting in. But we'll ring the bell. Nick, my man, will ring the bell to get you guys back in. This is what it sounds like. Fantastic. So when you hear that, please hurry back. We're going to start right away and try to stay on time. We will have a question and answer period available depending on how time flows. We'll have that facilitated by Mark Lefebvre, and we'll kind of play it by ear, but there will be a longer question and answer period at the end. So if you do have questions, make a note of them. You'll have the opportunity to ask. We will address online questions as well. For those of you watching this webinar, you do have the online question submission form, so complete that. We will get those questions, and again, we'll play it by ear. We will address your questions when you have them. A couple of things, refreshments are in the back. For those of you that haven't been here in a while, the bathrooms are just out the doors to the right. And because there's a virtual audience, we do have a very sensitive microphone up here. So if you can keep the side chatter to a minimum, if you can, that would be greatly appreciated. Thank you. In saying that, the last thing I just wanted to say is just a quick little story about how this all developed. And I told this story to the speakers last night at dinner. I tell this story to Mark all the time. It actually started on a dirty napkin. Just brainstorming ideas. There was a napkin on my desk, and Mark came in and he's like, "What are we going to do for the AGM?" And I was like, "I don't know. What do you think?" This is like modalities. There's a lot of great stuff out there. So I was like, "Well, who do we contact?" And we just wrote down some names. I can't find the napkin, but 3 of the speakers' names were on that napkin, and I just randomly, and I think random is a good word, I randomly emailed them. They had no idea who I was. I had no idea who they were. And they said yes. I ran to Mark's office, and I'm like, "Okay, so they said yes. What do we do?" And this is what happened. The side note to that story is I went to pick them up at the airport the other day. I have no idea what they looked like. They Googled me, so they had an idea what I looked like, but I didn't Google them. So I'm standing at the airport like this, and this is the actual sign that I was using. I was a little bit late, so I'm standing there like this, trying to see if I got an email. And then Jim says, "Dennis," and I look up, and I'm like, "Oh, it's you." And he goes, "Oh, your sign's upside down." And then I went like this, and I went, "No, it's not." Anyhow, that was my story. So let's just get this talk on the road. I want to introduce Brita. She's the president of the Alberta Athletic Therapists Association, and she'll be doing the introduction to the first speaker.
So before I begin and give my first introduction, I just want to take the moment to say thank you to Dennis Valdez, who definitely championed the leadership role in organizing this event. So can we just give him a round of applause? So it's great to see so many of you out here. I'm really excited to see you all here and for this event. So most of you know I do teach modalities as well, and we have 3 rock stars in modalities world with us. This is a chance of a lifetime, and I'm glad you're here to share with us. So our first speaker is Dr. James Bellew, and he comes to us from the University of Indianapolis. He has a long list of accomplishments and also wears many hats. In wearing those many hats, he's a full professor at the Credit School of Physical Therapy. He also holds his Bachelor of Science in Physical Therapy from Marquette University. He has his Master's of Science in Orthopedic Physical Therapy. And he is, most importantly, the co-author of this textbook, Modalities for Therapeutic Intervention. So if you didn't bring this textbook today, you missed out on your chance to get an autograph. If you already don't have it, I suggest it's a good bedtime read. Go and get one. Now we're going to welcome him up to give us a presentation.
Good afternoon. Thank you for your attendance, perhaps more importantly, your interest in therapeutic modalities. It's a great pleasure for me to be here. It's my first trip to Canada. I'd like to thank the Alberta Athletic Therapists Association, MedWest, Mount Royal University for the sponsorship of this. And I definitely would like to thank Dennis and Brita and the rest of the colleagues for their outstanding communication and organization in putting this event on. I can honestly say that this has been one of the most well-organized events that I've participated in. I'd like to talk with you this afternoon about neuromuscular electrical stimulation. I'd like to start by defining that as the use of electrical currents for purposes of increasing or retarding loss of strength. And I'd like to define the primary outcome measure of NMES as muscular force, or increase in muscular force or strength. And I'd like to differentiate that from many of the secondary outcome measures that are used that may include things like walking speed, pain, ligament laxity tests, time on crutches, time to treadmill, things, subjective questionnaires. And I'd like to bring your attention to this because oftentimes the secondary outcome measures are what's used to interpret the efficacy of NMES when its primary given outcome measure is suggested to be strength or force. So the question we'll start off with in a brief travel through the recent literature before getting out of the literature so as not to drown you in data and significance levels, etc. Who benefits from NMES? Well, I'd like to use this model to present this to you. Recently, a model was created from patients progressing to total knee arthroplasty that attempted to delineate or identify the primary underlying factors that lead to the precipitous loss in strength following the total knee arthroplasty procedure. These two intrinsic factors were identified as, these two factors were identified as one intrinsic at the level of the muscle fiber, that being fiber atrophy and fiber loss, and extrinsic loss or neural factors, primarily due to muscle activation and deficits noted at the motor unit level with a declining ability to activate or recruit motor units. While this model was originally created from patients proceeding or advancing on to total knee arthroplasty, it lends itself extremely well to other populations. So looking at our graph here, immediately post-operatively or post-injury in this case, there's a significant drop or reduction in strength. In the ensuing or initial period, and I'll use this cursor for all the people tuning in the first several weeks following injury or surgery, that decline in strength is largely related to recruitment factors, an inability to fire motor units, recruit them with the same synchrony that was capable beforehand. But as time progresses down our x-axis, and as we proceed from left to right, we see that as time proceeds, the intrinsic factors become a more significant factor with fiber loss and fiber atrophy. So in some manner, we can say that it is the neural factors that beget or contribute to or lead to the intrinsic factors or loss of fiber size, number, etc. Now, when we peruse through the literature and see, it is in this initial few weeks of strength deficit following surgery or injury where the evidence for NMES is most robust and most strong. If we look at the literature for NMES and look at the time sequence for when the NMES was administered, and we see that it falls outside of approximately a 6-week window, then we see that the efficacy for NMES is dramatically reduced. It's a factor I point out that's oftentimes overlooked in many of the reviews, many of the conclusions that are used to decide whether or not to approve, refer for, or pay for NMES. So more recently, there's been an increased interest in research of the efficacy of NMES. particularly in specific groups. So we'll talk about some of these systematic reviews in some of these patient populations right here. Throughout the literature, there continues to be problems, largely summarized as conflicting evidence. There's substantial variation in all sorts of aspects of study, from study design, patient selection, patient follow-up, and most certainly parameter selection, design, application, administration, down to electrodes, etc. Despite these deficiencies, there are still some strong consistencies that allow us to extract some information from the literature to be able to use our to guide our clinical decision making. So in 2011, a systematic review was published and assessed the use of NMES with rehabilitation versus rehabilitation alone in patients undergoing ligament and meniscal injury. It originally looked at 406 studies, but after administering the inclusion and exclusion criteria, that was whittled down to 19 studies. The outcome measures that the systematic review used to assess efficacy for NMES included quadriceps strength and a slew of what I would call the secondary outcome measurements, including performance tests, the KT1000 ligament laxity test, single limb stance time test, and walking speed and long arc. So the systematic review looked at those 19 studies and came up with a finding and suggested that strength was better in the group that received NMES at the 6-week period, no matter how it was measured, isometrically, by manual muscle test, or isokinetically. And it was reported as the evidence was best for NMES when it was applied within and over that 6-week period. So the subjects receiving the NMES showed functional improvements beyond the strength increases in strength. They showed improvements in range of motion, activities of daily living scales, walking velocity, and again, the single limb stance time test. But there were no significant differences between the two groups in parameters that were used to assess efficacy of NMES. That included the number of patients using crutches, the number of patients progressing to treadmill, pain, or the KT1000. And I would suggest, or ask you to consider, are those appropriate measures to assess the efficacy of NMES when its primary given purpose is to recruit or activate skeletal muscle for the purposes of increasing or retarding loss of strength. So the final conclusion from this systematic review for this patient population, or patient with ligament or meniscal injury, is that NMES combined with rehabilitation is better than rehabilitation alone up to 2 months. And I'll point out here that this is where sometimes people argue that there's no difference at 6 months or 1 year or 2 years, more commonly 1 year and 2 years often assessed. If there's no difference at 1 and 2 years, then does that warrant the use of NMES? What we know is that the patients that receive NMES, they reach the markers of functional improvement sooner than patients not receiving the NMES. And in quality of life scales, patients receiving the NMES score higher on those. Now in 2011, we also saw a systematic review that assessed the efficacy of NMES in patients undergoing ACL reconstruction. 301 studies were initially identified, and that was truncated down to 8 randomized controlled trials. The findings from the systematic review suggested that studies reporting increased strength also showed the subjects had the fewest number of sessions and a shorter duration of the rehabilitation period. The patients not demonstrating increase in strength were the inconclusive studies. Patients were all self-treated, and they all used battery-powered devices. 2 very contentious considerations in the use of NMES. The conclusion of this systematic review for patients undergoing ACL reconstruction is that best evidence suggests 4 weeks of clinically supervised NMES along with rehab. 2 of the 8 studies, that's the 2/8, 2 of the 8 studies reviewed suggested that NMES was not necessary for successful rehabilitation of the ACL reconstruction, but the effect sizes of all studies clearly suggested that NMES with exercise is warranted. Now in 2010, a very damning Cochrane review came out that looked at the use of NMES in patients that had received total knee arthroplasty. The problems with this review are very straightforward. They only included randomized controlled trials and controlled clinical trials. They came up with 2 studies that they then based their entire summation and their summation on. These 2 studies, while had their differences, their poor description of parameters, they used patients with end-stage OA, the ones most likely to proceed to the arthroplasty, and the conclusion from this Cochrane review that was picked up by the media and perpetuated throughout the United States was that there is insufficient data to recommend for or against the use of NMES for quadriceps strengthening in these patients undergoing total knee arthroplasty. Now, which side of that suggestion do you think the third-party reimbursers or the insurance companies picked up on? A unilateral myopic view. So I say that's why I proceeded by saying this was a very damaging or very damning Cochrane review. However, there was rebuttal to this. Since 2010, there have been 4 randomized controlled trials that looked at the use of NMES in patients undergoing total knee arthroplasty. NMES on postoperative strength and function in patients undergoing the total knee arthroplasty. 2 out of those 4 studies suggested NMES has a significant advantage over no NMES for increasing performance, including strength, and a variety of the secondary outcome measures that are more related to strength than are not, such as pain or ligament laxity. 1 of the 4 studies reported that NMES fails to increase performance better than progressive resistive exercises alone, but the assumption there was that the patients were able to complete the progressive resistive exercises, and if they weren't able to complete the progressive resistive exercises, they weren't included in the study. I'll come back to why that's significant and who NMES is targeted to help. 1 of the 4 studies was designed as a non-inferiority study. Non-inferiority study is basically designed to suggest that it's not a statistical difference between the 2, that one's better or not. It's that there's really one is not inferior in the outcomes. Although there are inconsistencies in these 4 studies between sample size, how or when the NMES was used, and the outcomes measured, there were still several takeaway points. So the takeaway points from these 4 randomized controlled trials that were in follow-up or in somewhat rebuttal to that initial Cochrane review that used 2 studies. 2 of the 4 studies suggested, 2 of the 4 studies that showed positive benefit, NMES was initiated on the 2nd post-operative day. 1 of the 4 studies showing no benefit NMES was not initiated until the 4th week post-operative. So the difference between NMES and the no NMES groups seemed to be most marked in the 1 to 2 week, at 1 to 2 months between those that received NMES and those that did not. So these 4 reviews collectively supports the assertion that NMES is most helpful when the activation deficits are the most pronounced. And that goes back to those neural factors. When the patient is unable to volitionally activate motor units, NMES has an advantage. And conversely, the benefits of NMES decrease almost exponentially if it's delayed or if we wait until the deficits are considered persistent. And it's very common in my area of the United States to not see a see a physician refer a patient for NMES until they've already been at their 6-week postoperative checkup and are showing quad deactivation, an extensor lag, or any sort, however it's described. At that point, we're well beyond, we're kind of at that optimal window and beyond 4 weeks, the most premium optimal window for the use of NMES. Now here's an area of NMES that a lot of people are not familiar with. The 2013 Cochrane review looked at the use of NMES in patients with advanced disease. There were 11 clinical trials used here, and the comparison was NMES versus no exercise or placebo NMES in patients with COPD, chronic heart failure, or thoracic cancer. The NMES was shown to improve quadriceps strength, the 6-minute walk test, and incremental and endurance shuttle walk test. And the suggestions, the conclusion of this Cochrane review suggested that NMES appears as effective means for improving muscle strength in patients, adult patients coming from these chronically ill patients. And it seems to be due to, as a result of addressing the underlying loss in strength that coexists with these pathologies. So to summarize the literature, the recent literature on MDS, when used properly, there's more benefit, there's more evidence to support the use of MDS than there is to refute it. But the people that want to refute it will latch on to a few poorly constructed conclusions from poorly constructed studies. NMES should be used early, an optimal window of 1 to 4 weeks, maybe reaching out to 1 to 6 weeks. In this period when recruitment is the primary limiting factor. And it appears also that NMES may offer subjective and objective benefits sooner by perhaps some of those secondary mechanisms, so a patient becoming ambulatory sooner, or not requiring crutches, or maybe being able to advance to a treadmill if that's the case. These are some of the data that suggest patients receiving NMES improve their quality of life sooner than populations not receiving NMES, despite the fact that at 1 and 2 years, there does not to be 1 and 2 years post-injury or post-operatively, there's not substantial evidence to suggest that NMES was better than no NMES that far out. It's in the more subacute time. All right, so we have evidence for why we should use NMES. Let's look at some of the recent considerations and evidence for why NMES works. So this will kind of start on a foundation that I'm assuming and confident that you're familiar with, but we'll put some new understanding to it. So let's consider volitional strength training first. We know that with volitional strength training, there's a time course to the adaptations in strength, such that in the initial 6-week period, we see relatively rapid improvements in strength, which then tend to decline thereafter. We know that the underlying factors here are both neural and intrinsic or peripheral from hypertrophy, but we know that hypertrophic response is delayed. And so it's clearly known that it is the underlying neural adaptations that occur within that 6 weeks that results in the significant and rapid increase in strength. This rapid 6-week increase in strength is largely mediated by changes in motor unit recruitment. We see increase in the frequency, size, numbers of motor units recruited, and we see a synchronization of motor units. Now, not ironically, but NMES also does all 4 of those things when applied to skeletal muscle. Now, from a practical basis, NMES should be considered an applied stimulus. It's an applied training stimulus used to offer an appropriate training dose to a patient that lacks sufficient volitional activation. NMES engages the neurophysiologic mechanisms, both intrinsic and extrinsic, that lead to an increase in strength. And I emphasize it is when the patient cannot do this. When the patient can do this, the efficacy for NMES is greatly reduced and is essentially not warranted. But it is that period, and again in that window, roughly 4 to 6 weeks, when the activation deficits are precipitating the intrinsic or peripheral changes at the level of skeletal muscle, that NMES is most warranted. So, I lived in Louisiana, in the United States, for a long time, and there's a reference to the holy trinity of Cajun cooking, onion, bell pepper, and celery. So I kind of adopted this theory for electrical stimulation, and I call it the holy trinity of electrotherapy. And this is the way I teach this. If you know the holy trinity of electrotherapy, and you understand some numbers, some parameter numbers to go with these 3 parameters, you are going to be a lot more successful than a lot of people that don't know the holy trinity. So let me offer some evidence for selections here, because there's always discussion about these parameters, what's best. And I'll keep this really straightforward. Frequency. We know clearly that there is a force-frequency relationship, and that between 50 and 80 hertz, or 50 and 80 pulses per second, or whatever parameter you want, and I won't split hairs with it right now, but whatever parameter you like, between 50 and 80 seems to be peak for listening force in skeletal muscle. Beyond 80, there's not an appreciable increase in force to warrant the sooner fatigue that will be induced by the higher frequency. And below 50 hertz or 50 pulses per second, we do not optimally contract that skeletal muscle for the purposes of strength training or developing strength. Pulse duration. We know now from a lot of studies, some of my own in the last few years, the longer the pulse duration, the more force we can elicit. Now keep in mind that this holy trinity is kind of like the Olympic circles as well. They're kind of all intertwined. You adjust one, you adjust another, and you get different effects. The longer duration of a pulse or a phase duration elicits greater force. It's been shown in a lot of multiple studies recently. Typically on a neuromuscular electrical stimulator, we'll see pulse duration ranges available between 200 and 1,000 microseconds. And I'm not familiar with every device that you have in Canada, but I know I took a tour of the facilities. I saw several Chattanooga units from Tennessee in the United States. I'm very familiar with those, so I know those run in that range. For comparison, Russian, which probably everyone and their mother is familiar with, has a cycle duration, or if I can refer to it as a pulse duration so that we're talking apples and apples. Russian uses a 400 microsecond duration. FYI, or for information or comparison, high volt pulse current is 100 microseconds, which is one of the reasons when I get questions and people are using high volt for NMES, I talk them out of it quickly because it's only 100 microseconds. And so what you need to do if you've got 100 microseconds, it's very, very short. What do you have to do in order to get a better contraction?
Increase the force.
Yeah, so you've got to crank up the amplitude generally. And then what do you think the patient tolerance is with that? All right, so the laughter in the crowd, right? So that's not going to lead to good efficacy. So despite the fact that high volt can elicit muscle contraction, doesn't mean it's good for it. I can eat Big Macs every day, but it's not good for it. I'll come back, or I'll come back. No, I'm not leaving, but I'll get to it later. But I'll show you some data from our studies recently where we've used 1,000 microseconds and what we've done with that. So that's extremely long. That's eternity. That's a millisecond. And the electrophysiology of milliseconds eternity. But the bottom line on this graphic here, as you can see, if we start widening out the pulse duration, essentially what happens is that's greater energy. So if you see that each one of those pulses maintains the same amplitude, if we increase the pulse duration, though, we're delivering more energy to that patient with each phase or each pulse. More energy, more force of the contraction up to a point. So here's this up to a point thing. Intensity or amplitude. Force is proportional to an intensity. It's up until that point where you depolarized or recruited all the recruitable motor units within that region of the electrical field. Once you've recruited them all, that's your peak force. This relies on the overload principle, which we know underlies adaptation. We must overload the capacity of the skeletal muscle in order to elicit adaptation. So, as intense as able. I'm going to answer how intense in a moment. If you put an NMES on a patient and you get a weak, wormy, squirmy contraction, and they're begging out, tapping out, saying that's enough, your NMES is not likely to be effective. Now, that may be the case on that situation, maybe the first initial exposure. You may need to work with that patient to convince them, educate them why they need a higher intensity to get a better contraction. But if all you can get is a wormy, squirmy contraction, ask yourself if you would get stronger doing that when you go to the gym. It's just not a proper stimulus. It will not overload. All right. So how much amplitude is enough? I like to refer to it like I do in pharmaceuticals or pharmacology. We need to refer to it as a dosage. We talk about dosage in other areas, laser, diatherm, ultrasound. We don't really talk about dosage in NMES. So this is something that I've been campaigning, I guess, about. We need to quantify what is the dosage we're using. I know I can only speak for my countrymen and their poor lack of documentation, but I'll go pick up a patient's chart and say, NMES, 20 minutes. Is that just one contraction for 20 minutes? What? I'm not really sure what that means, and I'm willing to bet money on the table that they use the default settings on the machine. So I probably have a good chance of repeating what they did just by not pushing any other button. All right, so training intensity, dosage. how do we address this? I'm going to recommend a lot of us that are experienced, which means older, we've made our mistakes already. A lot of us are suggesting use a training intensity of 70% of the uninvolved side. But we'll see some other studies, I'd like to say several, but few, actually document their dosage this way. We're going to look at some using 40 or 60%. That's 40 or 60% or 70% of the maximum voluntary isometric force of the uninvolved side. We have to assume that there is an uninvolved side, but I am for the sake of today's discussion. So the method to do this is really straightforward. You measure the maximum voluntary isometric force on the uninvolved side. Do it however you like. Sit a person down in a device such as on the screen. Determine what their max is on the uninvolved side. Then set up the patient for the appropriate neuromuscular electrical stimulation using the parameters and waveforms of your choice that I'm going to tell you what to use later. And turn up the intensity until you get a specific target of force for that involved side. A few weeks later, a week later, 2 weeks later, retest. This is really no different than in traditional design of strength training programs or when identifying appropriate heart rates or VO2 levels, target levels in the cardiorespiratory program. So this is how I do it. I shot this video in the clinic on the way last week before I came. Here is a friend of mine that's supposed to move. And there we go. All right, so he's going to take his right uninvolved side. I just got him on a weight stack over there, real simple. I could get fancy with a King-Com Lido or Biodex, but this works really well because I can just bend over real quickly and keep sticking a new weight in. It doesn't matter to me that that's 10 pounds at a time. And I keep going, When I get to a weight, I say, okay, go, and so I go back and say, okay, we're near as one RM. So for the sake of mathematics, you don't need to pull your phones out for it. My students pull out a calculator on the phone all the time, and I have them do 10 times 10. I'm sure you guys have got that. I just pick on my students because they pick on me. So now I've instrumented my subject here. I've got the device, I've got my neurostimulator, and I'm going to turn this up. I've set that weight stack now at, say, 70 pounds because his max was 100 on the other side. And what I do is I turn that up just until, come back down. So we'll assume that his max on the uninvolved side was 100 pounds. I went into training at 70% of that, so I pin in the weight at 70 pounds. If I explain that well enough, okay? All right, set him up, get my electrodes placed or whatever, and then I selected my waveform, I turn it up, I get to the amplitude that just causes that weight stack to move. You see the little yellow pin on there? And now that is what I will refer to as my dosage. So I know the parameters. I've got a waveform to document, a pulse duration, I've got a frequency, and I just cranked up the big wheel, I call it, on the amplitude dial, and I record an amplitude of 65 milliamps, or whatever it might have been for that particular patient. Kind of, letting that one roll. That's my dosage for that session. That's my dosage probably for that week. We'll retest the following week or the week after and determine, again, his NBIF on the other side probably won't change a whole lot, but now I can adjust my intensity if I so choose. Did I explain that well enough? It's a very simple technique. It only takes a few minutes, and if you can in your clinic, you can treat it right on that same device, as long as it's not one, a popular device in another patient or client needs it. Very simple, very quantitative, very repeatable. Everybody in here could repeat that if I documented that for that session. Okay, let's talk about waveforms. The thing that people are always asking me about. I get 2 or 3 emails a week. What about this? What about that? So when you have a multi-waveform generator like this Vector Genesis, it can be overwhelming. You whittle this down and you look at it, and it suggests that there's probably, 3 or 4 waveforms on there that you could use for muscle contraction. Let's take a look at it. All right, got to start with the king, right? Well, I'm going to knock the king down a little bit. Everybody's heard of Russian current, I assume. If you've taken modalities, you've heard of Russian current. It's burst modulated alternating current. That's all it is. BMAC. Burst modulated alternating current. Let's have a little fun here for a moment. I can't assume, I'd like to, everybody knows why it got its Russian name, but I want to tie it in to several other countries. It was named Russian because of a Russian exercise physiology named Dr. Yakov Katz created, so to say, this characteristic waveform of alternating current. It received its international recognition in what is considered its debut right here in your country, the 1976 Montreal Olympics, Summer Olympics. Ironically, does anybody know who won the men's decathlon that year? Bruce Jenner. What's Bruce Jenner doing these days? Russian current stuck around for decades. It was the go-to form. Many, many devices were sold with Russian current. Until Professor Alex Ward at the University of La Trobe in Australia began to question Russian current, saying, well, it's good, it's fine, but is there better? Can we find something that's better than that? So he started playing around with another form of burst-modulated alternating current, found that it was better, so I now refer to it as better Russian, and I'll give you some data and evidence on it. He created this waveform that was picked up by a company in Brazil, who is the sole manufacturer of what is now known as Alcy current. We have Russian current, now we have Alcy current. So it was in Brazil that Dr. Draper and I had the opportunity to meet and do some teaching down there, along with Professor Ward. And so now, here in 2015, Dave and I are in Canada, and so I'd just like to suggest it's a small world, but Canada guys have played a big part in the world of MES. So keep it up. Dennis, you're off to a good start. So, I don't want to go too far with Russian current, but I want to point out its defining characteristics. It's burst modulated alternating current, sinusoidal shape. This is a fast food Russian current, conventional. This is the branded name. We can vary it a little bit, but the Yakov Katz version is a 2500 hertz carrier frequency bursted at 50 bursts per second. That's the frequency. That's the frequency that your motor nerve sees, 50. So right within that force frequency range, this is why Russian current works. As a cycle duration, or if you will consider a pulse duration, I won't split hairs, but it's an alternating current, not pulse, but it has a duration of 400 microseconds, which is very sufficient for skeletal muscle or motor nerves. And it has this 10 millisecond burst interval with a 10 millisecond interburst interval, so 10 milliseconds on, 10 off. This is referred to as sometimes as a Russian duty cycle or a relative duty cycle. But the way I explain it is, when Russian current is on, it's on 50% of the time. So these are the three of the defining characteristics of why Russian current has worked for decades, while it still works. But I'm going to show you some better options. Another waveform, very, very common, symmetrical biphasic square. That's its shape. Anybody that's ever played with an Etch-a-Sketch as a kid, he can make these waveforms. My daughter's 4, she's making waveforms. We're going to name it something, I haven't figured it out yet. But a symmetrical biphasic square. This is the most commonly used waveform on handheld stimulators for years. Still very, very common, handheld stimulators. Pulse duration, and the manufacturers usually make this between 2 and 600. Sometimes they just average it out and make a fixed duration of 400 microseconds. And it typically has a frequency range between 30 and 80. So you can clearly get within your 50 to 80 peak range for strength. There's 2 reasons this waveform works. I'm not saying it's bad. It's 2 reasons it works for MES. Because of its rectangular square shape, it has a relatively instantaneous rate of rise. And when it is on at peak amplitude the entire time. So what this means is, for the area under the curve, that slightly, I don't know if you want to call it darker, Mount Royal blue color, maybe I hope I'm close to blue, but the color inside the square, because that is instantaneous rise and it stays at that peak the entire time, the area inside that phase is greater than if it were ramped up and down. And I want you to hold that thought in mind when we start talking about areas within the curve and what that means. And that parameter is phase charge. Phase charge. Now, Chattanooga Company out of the United States took this symmetrical biphasic waveform back in the 80s, and based on some evidence that of using what's called an interphase or intra-pulse interval, they noted from paper from Bowman and Baker that they can get the same force output at 10% less amplitude. That was the initial impetus for this interphase interval. And so this is what the proprietary VMS waveform is. So if you watch Antiques Roadshow, you might see a VMS stimulator unit, or if you go into your intellects, the vector genesis, a sub button of your electrical stimulation button, usually oftentimes will have VMS. That's what this is. More recently, this idea of the use of the interphase interval was substantiated by Laufer when, I believe she, looked at this and used a variety of different interphase intervals and noted that on the far right of that screen, interphase intervals of 150, 250 microseconds versus no interphase interval or 10, 50. The higher interphase intervals elicited greater muscle force than the use of lesser or no interphase intervals. So you don't have, the devices that I've seen here, you don't have an option for changing that interphase interval, but it substantiates the use of a VMS waveform, not that I'm advertising for Chattanooga, but it is a waveform that offers you that interphase interval, which the strict symmetrical biphasic does not. So VMS was pretty good. So they came along with a new waveform, not relatively new anymore, I've said that long enough that I can't say that anymore. A waveform called VMS burst. I refer to this as burst modulated biphasic pulse current. What this is a combo meal. This is a hybrid. This is combining the bursting of brushing and the shape and the interphase interval that we see with VMS. So it's taking key features of two things and combining them. I don't know if the intellect in the lab has this. I'm using Genesis a lot more. But if you have this VMS burst, what it is it's three symmetrical biphasic pulses elicited together in a burst. It uses a fixed, meaning unchangeable, fixed interphase interval of 100 microseconds, which is the proprietary creation of Chattanooga. And it bursts it at a frequency that you set it at. So conventional Russian uses a burst frequency of 50. If you so choose, you can use 50, 60, 70, 80. If your purposes are for increasing strength, shoot between 50 and 80. You set it. It has a variable pulse duration. You actually, on the Chattanooga units, end up setting phase duration. So you have to be a little careful. If you set 400 microsecond phase duration, you've got to double that for the biphasic pulse. So you can select a longer phase duration, which the evidence supports, and I'm going to continue to show you some evidence for these waveforms. So that then kind of leads to this Alcy current, which I refer to as beta Russian or burst modulated alternating current. Well, that's also what Russian is, but this is modified Russian as well. I'm not sure that this is available in Canada yet. They recently came into the United States about a year and a half ago and starting to make some impact there. Here's what Alcy current is. Keep in mind what Russian is, but I've also given you kind of contrasting data. Alcy current uses a 1 kilohertz or a 1,000 hertz AC carrier frequency, which is different than Russian, which was 2,500. Alcy current uses a 2 millisecond burst duration, sometimes even 4, but characteristically 2, in contrast to the 10 millisecond burst duration of Russian. and also uses a 10% duty cycle versus the 50% of Russian. So I'll point it out here, and I'm going to elucidate on this later. The 2500 hertz carrier frequency of Russian, the frequency, that yields the 400 microsecond cycle duration. One cycle of AC, 400 microseconds for Russian. With ALSI having a 1000 hertz carrier frequency, the inverse of that, 1 over 1000, is 1000 microseconds. So decreasing the frequency elongates that sine wave, and it's going to result in, I'm going to show you, it's going to result in greater force. So those are all waveforms that are, with the exception of ALSI for a while until it comes to Canada, that you have at your disposal. So I give you this information for clinical decision making. What are you going to choose and what's best? Right, so which one? Let's look at Russian and ALSI. So Alex Ward, several papers by Alex Ward. You look his name up, some very excellent papers. He looked at muscle force production, or torque. He looked at torque and using a variety of different carrier frequencies and duty cycles. And he showed that in the blue arrow at the top, a 1 kilohertz or 1000 hertz carrier frequency yields significantly greater muscle force than the 2.5 kilohertz, or the 2.5 kilohertz, 2500 hertz duty cycle. And that at the blue arrow there represents a 10, or combined a 10 or 12.5% duty cycle. That yielded significantly greater force than the 50% duty cycle of Russian. And this is again with a lesser carrier frequency, lesser burst duration, and a lesser duty cycle. So what about this concept of the effect on shape? I told you about the etch-a-sketch, and I'm assuming that's a universal torque, correct? All right. Anymore, I don't assume a whole lot. But if you play with etch-a-sketch and you start playing around, if you ever took geometry and trig and everything, and you painfully remember that, you should easily remember areas under the curve. Well, I went back and looked at some engineering data and some studies, and there was a really nice paper back in 1980 from Bangkok, who looked at the different shapes. And he looked at an alternating waveform. Now, if you consider the x and y variables, you got etch-a-sketch with you, right? Going x and y, going left and right. So if you made a sine wave like that, and then you superimposed over it a square, or a rectangle for that matter, just that has the same duration and the same amplitude, will look something like that. And now consider area under the curve. So for the same x and y, the same duration and the same amplitude, looks the same on paper. I've got the same duration, I've got the same amplitude, but the shape now makes a big impact. There's approximately one third greater charge in that square or rectangular form over the sinusoidal form. If I can deliver 1/3 more stimulus to the patient, it makes sense that we get a greater elicitation of force. So this concept of greater torque with greater phase charge was substantiated by Wayne Scott in the United States, looking at a variety of phase charges, so making the area under the curve greater, getting more force. So in 2012, we published a paper that looked at it this way. We said, okay, Russian's good. What about this hybrid thing, that burst modulated biphasic pulse current, the one that's kind of a hybrid of VMS and Russian? So we said, okay, let's keep the parameters that are common the same. So we use the same frequency, the same phase duration, and we use the same amplitude. Let's see how much force we get at 100 milliamps. But the dissimilarities were right here, and particularly right over there. We use a lesser carrier frequency, a lesser burst duration, a lesser duty cycle, and the key thing is we have that rectangular shape as opposed to sinusoidal. So we turn it up to 100 milliamps, record force, and what do we find? That burst modulated current yielded 63% of the maximal voluntary force. Russian elicited only 36%. If that's a training stimulus, or you go to the gym to work out, and you use 63 pounds or 36 pounds, you know which one's going to make you stronger, sooner, better, faster, quicker, smarter, right? That's the evidence behind why we choose certain waveforms over another, and we get a greater training stimulus. So then combining some of this evidence, when we look at Ward's papers and studies that suggest that lesser carrier frequency, lesser burst duration, etc., yields greater force. We look at our work, we look at Bankoff suggesting that shape makes a difference, and we look at Wayne Scott's work that suggests phase charge is important. We came along and more recently looked at something rather simplistic. We just took one of the Chattanooga units and said, okay, let's just simply change the phase duration. By doing so, we can effectively change the phase charge. So we set a 400 microsecond phase duration, and we used a 120 microsecond phase duration. And the reason we picked that is because we couldn't precisely get what we wanted to make a 2500 hertz carrier frequency, just as a limitation of the parameters available to us. But we tried to approximate it to get to 2500 hertz. So we had a longer pulse duration that was due to a lesser carrier frequency, much like Ward looked at. And we looked at a higher carrier frequency, which meant that the sine waves were coming more frequently, which meant that the phase duration was shorter. And so what did we find here? We found what I sometimes refer to as the white whale. We found near 100% elicitation, 100% of the maximal voluntary force with the use of that burst modulated biphasic pulse current using a lesser carrier frequency versus 40% of the maximal voluntary isometric force. And I contrast this into sort of a global survey of the data on NMES. And typically, studies using NMES are eliciting forces in the range of 30 to 60% of the maximal voluntary isometric. So to be able to train at near 100% or peak has been somewhat elusive to this point. And so we've been doing this, and we've got plenty of other people collecting data and seeing the same thing, simply using a proprietary waveform that's available to many people just by modifying, go in the edit button. The edit button is your friend, I teach everybody. So wrapping this up, where are we now? Evidence for NMES is robust. Probably as robust as it ever has been. New evidence for waveform parameters, waveform shape, selection of these, it continues. We're getting more and more new data out all the time. With that, however, quality training studies are relatively sparse. We have some decent ones from select populations. We have these newer ones from the patients with advanced disease, or there's still a relative sparsity of quality training studies. And another limiting factor that we were talking about since we've arrived is this bias against electrophysical agents, which seems to be sort of the precedent for how we got to the idea of this conference in the first place. And that if there's a bias against electrophysical agents, this may limit its use and therefore limit its extendability out to the patients that need it. So what conclusions can we say? Neuromuscular electrical stimulation is a tool. It needs to be used selectively, not randomly. It needs to be used on patients who have appropriately been identified as having difficulty with volitional recruitment. And it needs to be used within a suitable time frame. So if you have to campaign, recruit, or advertise, or whatever you need to do to convince, in our case, referral sources, to be able to get those patients or advise the physician on how to recognize a patient that needs it, so be it. But get those patients on it sooner. We now know, too, that the benefit of NMES seems to exist or extend beyond the athlete, largely coming from the studies coming from those patients with advanced disease. And right now, we probably have the best evidence ever to support the selections of parameters and waveforms. So I encourage you to use it. I'm going to wrap up there with, again, a final thanks to our sponsors, and I'll be happy to entertain questions now or later, whichever it may come, and after the sessions as well. Thank you very much for your time.
So just being aware of the time, we have 5 minutes to entertain questions. Mark's going to facilitate this, and I'll get the next speaker ready. So I'll hand it over to Mark.
All right. So thank you very much. That was great. And I know we have a lot of alumni here, and I'm wondering if I've taught anybody outside of Larry and me back in the 90s. Because one of the things that and so while you're thinking about your questions, one of the things that I noticed, and I told you the story earlier, but I went on sabbatical a couple of years ago when I came back, and when I came back I was preparing to teach the modalities course again. I would look for new and great things, and so his work is some of the new and great stuff that I think I've discovered as I was doing research. And one of the things that I taught back in the 90s was that waveform didn't matter. So if you go back to the Nilsson and Courier books back in the 90s, they'll say that waveform didn't matter. And I think it's a really, and so I don't know if I've taught that to anybody at any point, but I want to take it back. I know I didn't teach it last year to the folks that were in the program because I've been using his new research, but waveform does matter. And I think that's one of the key messages in your story today. So I'll stop talking. Any questions from the audience that are here, and then how about online? So people that are online, feel free to type your questions in if you have any. Yeah, Tim.
Sorry, you made a comment about a battery-powered NMES versus, one that's connected to the modalities. Is there a difference clinically if we use the handheld versus the machine?
Can I repeat the question?
Yeah. Yes, please.
So I made a comment earlier that one of the limitations in studies is the use of battery-powered devices. And until a few years ago, and I do not work for any company, until a few years ago, the handheld devices had been shown to be inferior, specifically in the listening force compared to line-powered plug-in units. Then came along the MP unit called the 300 PV. This 300 PV, don't write it down because it doesn't exist anymore. Fitzgerald et al., I can't recall the year, Fitzgerald et al., I believe was the one who put out the paper that showed that for the first time ever, a handheld unit was comparable to, not different, than the line-powered units. Now, that uses a symmetrical biphasic square. Off the top of my head, I don't remember what it was that they used as their waveform for the plug-in unit, but the guts, if you will, of the 300 PV are now part of the MP continuum. I do not work for them. I'm not advertising. I'm telling you what's available to you. So the 300, the continuum, now has the guts of the 300 PV, and I can't say so confidently that the MP Phoenix, which is a garnet-wrapped, embedded electrode handheld battery-powered unit, if that has the same guts or not. Excellent question.
Yeah, so on that note, one of the reasons why we brought the machines here today is because based on the research that I've done, we've been buying new machines for teaching students. And so, and that was one of my questions was, you have no bias towards Chattanooga. It just so happens that they're the ones that create the VMS and the VMS burst that you advocate for and the ones that you're doing research on.
I'm not paid by any of them. I just use what's there. I have a friend who's a biomedical engineer. Radio Shack is one of our favorite stores. We go and we make things. He makes things, and I shock people with them. Or he takes apart a vectorgenesis, or takes apart a device and allows us to manipulate the variables. Because I don't exist in a major research institution that pays us to do that per se. But sometimes we create our own stimulators to see what the effect would be, and then we say, well, what's the closest thing to this on the market? So years ago, when I started identifying this VMS burst, I said, well, that sounds pretty similar to what this biomedical engineer of mine was doing. Let's try it out.
Perfect. And Larry, which units have it and which ones don't? For those of you, before you go any further, that's Larry Mack, I'm sure everybody. Does everybody know Larry? Larry is the primary director with MedWest. But Larry, what are the units that have the VMS first?
Just currently the intellect advanced.
Do you get the Genesis here?
That's the comparison to the US.
Okay. So good. So knowledge for me to take on. Good. So I want to just emphasize that these are things that in the clinic we just started asking, and Alex Ward, he's one of those guys that are kind of on the same wavelength. We just started always asking, so is there better? Is there better? And until we find perfect, which we never will, we keep asking better. So it's just the use of clinical inquiry to feed your research.
Other questions?
You said NMES is only indicated for people that have neural deficits post-surgery. Clinically, how do we test or know the difference between neural deficit and just structure deficit or muscle fiber?
Okay, so I suggested that it's more indicated, when we track the word only, but don't like those extremes. It's more indicated for patients with neural deficit. And what I mean by that is recruitment issues. And so clinically, I'm not going to do EMG on them to determine that, but I might look at, for extensor lag, a comparative sign. Are they able to generate as robust a quadricep contraction as the other side? Are they able to isometric knee extension, whatever may be indicated for that patient, and their post-operative or post-injury considerations. If it seems to be recruitment, if it's acute post-operatively, it's not intrinsic yet. They haven't yet had that significant enough atrophy or fiber loss to account for that as much as it would be activation deficits. Did I explain that?
Yeah.
Okay. Thank you for the question.
Maybe along, yeah, go ahead.
Sorry, okay, one more question. So if I have a symmetrical biphasic square waveform for my patient, and I set a 1 second ramp for comfort, if I extend that to 3 seconds to make it more comfortable, is that going to change my waveform into a sinusoidal waveform? Or?
I don't know. Because you need to pull out the manual and see. Okay. And this is why. Because we don't know, and the only way to know this is to look at the manufacturer. So if you select, let's say here's your 3 seconds, if that's right. But you also decide to put in a 1 second ramp. What we don't know, and you have to look if that 1 second ramp is part of the 3 seconds or not.
Okay.
It may be or it may not be. You have to look at the way. So if it is, if it's not, then you actually have additional energy delivered to that patient, same as if you do a fall. Okay. And if it is part of it, which a lot of people do, they want a 10-second contraction, but they do a 2 second rise and fall. That might mean they're really only at peak for 60%, 6 out of 10 in this case, 60% of the time. And these are considerations that are easily overlooked. But a great question, pull up in the manual and see what they got.
I'm going to do a follow-up to his question, if you don't mind, and then you guys can think about your question. So you use the time frame of 6 weeks as that kind of golden time frame that in the first 6 weeks post-surgery or post-acute injury that you'll get the best effects with muscle stim. So further along his question though, what happens if you get somebody that has patellofemoral pain and they're not firing their VMO for whatever reason, because of the pain we assume? Would you put them into that category even though they've had patellofemoral syndrome for a year? Would you if they're not able to fire that muscle appropriately and timing-wise, would you still put them into that 6 week period?
So good question. First of all, I'll say the 6 weeks is really kind of what evidence is telling us 4 weeks may be better. And in an example of the patient with the chronic patellofemoral mechanism dysfunction and maybe pain, I'm looking at that as that's a different scenario because that's not post-operatively or post-injury. That's a different scenario. We're going to have a different mechanism for the loss in strength. It may not really be the predominance of neural that we depict from the graphic that I was identifying earlier when we get loss of volitional recruitment following the injury or post-operatively when we have edema, neural inhibition, etc. in this case. So in that particular patient, the use of a neuromuscular electrical stimulation may become what might be called neuromuscular re-ed. So active contractions of VMO assisted by the electrical stimulation and maybe not driving for the peak forces that we're trying to get under what I'll refer to as just straightforward traditional NMES when we're trying to drive stimulus to get the greatest force possible. Did I explain that? Okay, that was a good question. Good to know that.
Maybe just one more question, then we'll take a break. Dennis? Yeah. Okay.
Well, very good. Well, thank you, Jim, for a great presentation. We'll take a 5-minute break. I'll start my clock because I normally do. 5-minute break. We'll ring the bell at 4, so we'll see you back in 4 minutes.